I'm Brooke Charters and I'm a paediatric emergency nurse working at the Gold Coast Hospital in Queensland. When I left school, I didn't quite know what I wanted to do, so I did a bit of everything. I went into disability and discovered that's when I wanted to do nursing. So I went to university at Southern Cross and did my Bachelor of Nursing. And from there, as one of my placements, I went over to Africa. And that was a big turning moment for me because I thought I wanted to go into nursing to do mental health nursing, but actually discovered paediatrics while I was over there. When I qualified as a nurse, I did my graduate position as a paediatric emergency nurse, and that saw me do 6 months in the mixed ED, but in a paediatric section at Logan, and then I went up to the ward for 6 months and did some paediatric nursing upstairs. Once I completed that, I did my postgrad in acute because I knew that I liked emergency nursing. From there, I then went on and did 13 years of paediatric only emergency nursing. I first wanted to start studying paediatric mental health. I felt that that was something that we didn't do so well in the emergency department. We see kids come in, they have a bit of trauma and we think, oh, they're so resilient, we send them home with no further interventions. But years later, we've seen them coming back for further interventions. They might have generalised anxiety or some other mental health conditions. So I felt as a nurse that we didn't always want that medical lead, and I wanted to start my PhD and study into the kids' mental health. Along that journey, I had sort of found a research role and started in there, and that was where I learnt a few skills on how to do research, working with some of the Predict network and with other people in the department that had done research. This is where I found a bit of a niche love, and one day I was approached by the paediatric coordinator for Queensland who'd asked if there was any ideas that I wanted to do in research, and it had just happened that on that night shift before I'd had another clinical incidence of losing cannulas that led me into doing a study at securing cannulas better because we were constantly losing them. We lose about 1 in 4 cannulas in children, which was on par with national data that we were seeing. So I thought there had to be a better way to do this. Once I had that conversation with the coordinator of Queensland research in paediatrics, it sort of unfolded really, really quickly. I was meeting teams of specialists that had skills in research. I was meeting a biostatistician, a health economist, and I was starting to meet people that specialised in inserting cannulas and in securing them. With cannulas falling out in children, we know that nationally we were losing 1 in 4 when I looked into it, which was a lot of cannulas. And then you're talking about these children needing more and more cannulas inserted for their treatment. Most of the time these dressings were either falling off or they were just sliding out from under the dressings. I wanted something that would stop that from happening and try and save those cannulas for the kids and save that trauma of reinsertion. The study that we undertook looked at a randomised control trial, and what we did was 3 arms. We looked at comparing our standard care in the department that we were already using versus 2 different arms. The first one looked at an integrated dressing that we hadn't used before, and then that other arm was using that same integrated dressing with a tissue adhesive to help at the time to see if one would reduce over the other. We enrolled patients that were 6 months to 8 years because we knew that they were the risky groups that nationally tended to lose the cannulas more, so that we could assess the data to see if we were going to help save those risky patients. We enrolled them if they were going to have a ward admission for more than 24 hours. That was part of our requirement, and 24 hours could mean short stay in the department or it could mean going up to the ward itself. These patients weren't to be enrolled again, so if they'd already been a patient in the department and on the study, they weren't re-included, so that we were grabbing new data and new feedback all the time as well. And we didn't obviously enrol people that had a known allergy to the products or to non-English speaking backgrounds without actual consent as well. When we collected all our data, we found that the third arm, so using the integrated dressing along with the tissue adhesive, significantly reduced the cannulas. It was quite exciting at the time. We'd looked at statistics and that we needed to get over 410 patients. Unfortunately, a little event happened at the time that delayed us getting all our patients, and we only got to 383 patients. But our biostatistician did the numbers and it found that even with a few decreased numbers, that it was still statistically improving or reducing, if you will, the number of cannulas that we were losing, and it didn't drop off even without the numbers lost. It still showed very effective, which was that dressing and the tissue adhesive together. It was really exciting at the time. I think something that else was very significant at the time, we captured data to see staff satisfaction and patient satisfaction from these products as well. And what I found quite interesting was that staff actually liked the product, and traditionally when I'd done a little bit of the research for the department, we'd found it very hard to implement change. So it was another nice outcome to see.
So for me, getting an EMF grant has meant that we can try and find that best solution, reducing that fear in children, reducing that cost in the hospital, and making a better product that's going to last longer for the children.
It's been such a big whirlwind since doing the study. I think back to the start from this amazing opportunity when the Emergency Medicine Foundation first opened. It was around 2018 when they opened the first time to nurses. So I was the first nurse to get the grant from EMF, which was already a big moment for me. Then when we collected the data, we realised as we did the outcomes that it was also the world's largest study at the time for securement in children. And then I went on to publish in JAMA Paediatrics, which is one of the largest in the world. So it was quite a big head moment for me, and such a great thing to see that it was going to help so many children. I've had lots of feedback from lots of people saying that they want to implement this, and the hospitals that did the study are actually using the products already. And now working here at Gold Coast, after doing a talk at the symposium, I've been approached to start implementing it here, and we're currently in the process of rolling out all the education and ordering the products. The big part of passion for my work is seeing that the kids aren't getting stressed from things that we're doing to them. It's already something that's quite intense for a child to go through. It's not just intense for the child to go through it, it's usually a carer, the family going through that. And if you're thinking about a cannula failing and having to redo that, it was always stressful for me as a clinician as well. So doing this sort of work's been great because I've seen that personal reduction in this happening. A big part of my career has always been about reducing fear and anxiety, and I think it's such an honour to be part of that child and family's first journey, and we can set up and create the way that they see healthcare systems later. So I have found this quite satisfying.